कैमली इज अ इंग्लिश लर्निंग ऐप. कैमली ऐसा इंग्लिश तो आप बहुत तरीकों से सीख सकते हो, बुक से भी सीख सकते हो, यस. बट बात जो मैं कह रहा हूँ ना, आपको अच्छी इंग्लिश चाहिए लाइफ में आगे बढ़ने के लिए.
हेलो हेलो हेलो. हेलो 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 हेलो
Are you worried that your child won't get into a good kindergarten? Why do some kids seem so smart at such a young age? Create a Class, an intellectual development program for children aged 3 to 8, provides a fast and easy way for your kids to get
Good morning, everybody. We start with the first part of this 2 days academic quiz, and we have workshop endoscopy approaches for the skull base, and there are 4-5 lectures before we start the workshops, just to understand how these approaches are being used when we do the lesions here. So we have kept 4-5 lectures just to understand this, and we start with this lecture, and after that we go down to the cadaver lab. There will be demonstration and followed by the hands-on workshop. So I, from the on behalf of organizing committee, a warm welcome to everybody, and I think it will be a good academic feast. Thank you very much. And now I invite Dr. Dev Pujari for his first talk on the pituitary and its surgical implications. Thank you.
Thanks, Dr. Rajneesh, and good morning to all of you who have made it here early morning today. I am the opening batsman, but I think we'll not take it like a 2020 match. I am from the test match generation, so I will start slowly explaining some of the intricacies of this surgery. But what I thought I would do is actually to share an unedited video with you. Maybe we'll have to fast forward it because I have very short time, but we'll try to cover some of the points which are important for those who are in the early part of their endoscopic endonasal surgery career. So basically, I think the responsibility is huge. If you look at the prevalence of pituitary adenomas, though similar figures are not available for India, the numbers are very, very alarming. Actually, the authors found an overall estimated prevalence of pituitary adenomas 16.7% in autopsy studies and 22.5% in radiological studies, which actually means that every fifth person harbors a pituitary tumor. Does not necessarily mean that it will be recognized during the lifetime or will need surgery, but it is as prevalent as that. And in some parts of the world, like the study from Utah shows, which Dr. Kuldwell has shared with many of us in his Indian talks, it seems to be more common than that. So probably there is some kind of a predisposition. We do not have a clear idea about what is the incidence in India, but I think all of us are seeing many more cases than what we used to see earlier. Now, why it is important? It is important mainly because the early part of pituitary surgery developed on the hormonal clinical presentation, because that was more alarming, and most of the early reports you will find are based on that. And then the visual thing also, became equally important. And I think the advent of probably endonasal surgery came about mainly for the need for microadenomas, because macroadenomas were getting removed by transcranial surgery anyway. From transcranial surgery, of course, diaphragm oculi is the barrier between the brain and the pituitary gland, apart from a small opening for the stalk. And the blood supply of pituitary and optic apparatus is very important to understand, and which also tells us why the endoscopic or for that matter any kind of transsphenoidal approach is better than going transcranially to preserve all these structures. What has also helped us in deciding what kind of surgery should be done is the Hardy's classification, which was the first classification came for the surgery for pituitary tumors, and the NOSP classification which followed that, which has been actually redone recently with the help of endoscopic surgery and MRI characteristics. Dr. Goyal has of course given another classification for giant tumors, but I think we can talk about it later during one of our lectures later on. Today what is most important is classification is important for not only the size and the direction of spread, but also the invasion. And I think this is an important classification which has come up in 2020. Good morning, Dr. Suri. No, secretary is the most important person. Without him, programs are difficult to start. So anyway, what we'll do is get to the point of practical, which is the purpose of the talks today. And I'll just describe you a case of a 47-year-old man who came with diminution of vision in the right temporal aspect. Also then started developing headache, vomiting. One of the things is the vision, if it is partial and if it is only on one side, most people tend to ignore it, go to the eye doctor who also may or may not do confrontation or perimetry, and we get patients unfortunately still very late when they are developed bitemporal hemianopia. So this is the kind of tumor which is a regular kind of a tumor which we see. There is a proper globular suprasellar extension going into the third ventricle. You can see involvement of both the cavernous sinuses, but our good luck is that it still remains inside the cavernous sinus boundary, maybe a little bit of overflow on the left side. This is the sagittal view, and after MRI, I mean, I don't think there are many people in the audience who have worked on these tumors before the advent of MRI, so it is not much point in talking about that. But earlier it was difficult to know and therefore difficult to plan these things, but it is much easier today. You can see the spread quite well, and also I must mention the fact that NIMHANS has come out with a new classification based on in which direction the tumor is going. I still find that most of the classifications in terms of outcome are still not so good, because they do not take into consideration the consistency of the lesion and the vascularity of the lesion, etc. But I think we'll leave that for another time. So you need to examine this in all the three dimensions. This is the axial. Also important according to me is the T2 weighted sequence. T2 weighted sequence is very important to see how the tumor behaves on T2 weighted sequence. Does it become hyperintense? Does it become hypointense? Does it remain more or less the same? Is it granular? Does it show any evidence of blood? And evidence of blood, granularity or some cystic degeneration, and most importantly tumor becoming T2 hyperintense are good criteria for you to take this tumor out by suction and gentle curating. One of the other important things that has happened with endonasal endoscopic surgery is, with the speculum in place, there was no way you could go beyond that 10 to 12 millimeter space which was given to you, unless you maneuvered it a lot, and Dr. Goel is the only person I know who still continues to do that, because most other people, if they want to go anteriorly, laterally, etc., they would prefer to do endoscopic procedure. And here, apart from seeing the depression in the cellar floor, etc., you also want to know where is the septum, which is very important consideration as far as your exposure is concerned. You will find that almost 2/3 of the septum end up on one side of the carotid artery, and therefore that is also very important to know. So here you can see the midline, the septum. So important thing is that you must also do a CT scan, which has become an additional investigation necessary if you want to do an endoscopic approach, because you want to know if you will be able to do a paraseptal approach, if you are going to be able to, which nostril to enter in, etc. And all this can be found out on the basis of the CT scan images quite effectively. And as I was just saying, that this gives you a good idea if the septum is ending on the carotid, like probably this one does, and if you have any polyps or any other abnormality on these scans. Sagittal scan is important to see how much of the sella is actually exposed as soon as you open the sphenoid sinus, and it gives you a good idea if you will be able to approach most of it. Sometimes, many a times in fact, the clivus top or the dorsum sellae area is heavily ossified, and if the tumor is large enough, or if it is going posteriorly or superiorly too much, then you need to drill that out as well. So basically there are varieties of endoscopic endonasal approach. It's transseptal approach is the most common, which many of us found earlier when we were not familiar, and if you want to do an extended approach, we still do it, and many ENT surgeons favor it, though preservation of middle turbinate can be done at least on one side in most of the cases, but by doing middle turbinectomy you get a much better corridor. Two nostril approach, I think middle turbinectomy is not necessary, but it depends on what kind of a cavity you get. And transseptal approach is where we started, and paraseptal approach is where we are ending, even if we are doing a two nostril approach today. one thing important to understand is you are, as a neurosurgeon, you are allowed to go to the medial part, medial aspect of the turbinate, leave the lateral aspect of turbinate and the lateral part to your ENT colleague. If you do not have a good ENT colleague with you, if you need to chase the lateral parts also, then you must make yourself familiar with that anatomy as well. So this is one patient where we started with middle turbinectomy, which certainly gives you more space. And the important thing is to not take out the whole turbinate, just pull it out. You cut it, you keep its cranial end intact so that you do not damage the olfaction and you do not damage the olfactory part of the anterior skull base. I will not take you any further. For the paraseptal approach, localizing the sphenoid ostium is very important. Opening the anterior sphenoidal wall is very important. You start cutting, drilling or biting below. Never try to go up. First see the bottom of the sphenoid before you start going towards the top. Then once you have opened sphenoid enough, once you have taken care of the septae, then open the anterior cellular wall, then removal of the tumor, and I am sure there will be several talks which will tell you all this, and I will show you during one of the cases which I will show you in a minute. So most important thing is to reach the sphenoid ostium, which is usually about 1.5 centimeters above the choana, which is the standard landmark. You can say bottom of the superior turbinate, top of the middle turbinate, and if the mucosa is not inflamed, you can easily walk in. If it is not, then you need to probably just gently put your suction and you will enter it anyway. These are the kind of landmarks which you see. If you need to go anteriorly, you need to do ethmoidectomy to see that you have not only reached the anterior part of the sella but also gone and opened the anterior planum sphenoidal, and posteriorly you need to be care of the nasopalatine artery. Earlier we used to talk only about its significance for bleeding, but today it is a most important structure to preserve to make the Hadat flap. And when you get multiple septae like this, it used to be very difficult during the microscopic era to find out where exactly you are supposed to go, but the panoramic views in endoscopy gives you a chance to actually find what is the midline and gives us a time to actually identify the sella completely. So sphenoid sinus and its relationship to the internal carotid arteries is an important consideration before you undertake this surgery, and the analysis shows that almost 2/3 of the septae end up on the carotid artery, so keep that in mind. Then you can open the cellar floor wall either by doing flap or doing drilling or whatever. Earlier I used to prefer flap, but today I am mostly doing drilling of this to get to the proper margins. And what is important, and I think the biggest advantage of endoscopic endonasal approach is that you can see this anatomy beautifully, carotid to carotid, pituitary gland, the small gap in front. If you retract it behind, you can see the mammillary body is basilar. If you retract above, you can see the anterior cerebellar arteries and the interhemispheric fissure on the top. I will now stop my talk and I will take you to a live case, live in the sense that I'll take you to a case where we have an unedited video, and I'll run as much as I am allowed to run. So what we do is we either do a electromagnetic navigation because we are not fixing the head. If you are fixing the head with the Mayfield clamp, then you can do optical navigation. Otherwise नहीं दिख रहा है तो कैसे करें, देखिए आप, ये वाला दिखाना है. Sorry about this. नहीं, मुझे नहीं लगता उसमें कोई प्रॉब्लम है. Video is here. Open. डुप्लीकेट करोगे तो आसान रहेगा. हाँ, बढ़िया. So here I am using striker navigation, which actually has something called a face mask. where the fiducials are on the face mask, and that also gives you a good localization for your navigation. Otherwise, EM navigations which are available with Medtronic and now currently become available with Scopus also can be used for this kind of surgery. I would recommend this to be used if you have some anomalies of bony or vascular anatomy, or if you are doing a recurrent case, and certainly for all expanded cases. So once you have taken that, then you start off. This is my ENT colleague Dr. Shah, who has taken immense interest, and I give him credit for not only sustaining interest but continuously improving our technique further. So first you do a diagnostic scopy. You have we usually infiltrate with lignocaine adrenaline. The middle turbinate is being sort of injected, so that I think there is this kind of a bulla, and you can resect. Actually, you can make a vertical incision and make your cavity wider. ENT surgeons, I'm sure, would do it routinely. For neurosurgeons, it's not such a common thing. That's why I'm trying to show this. And then we are trying to get to the sphenoid sinus. What you must have seen is use broad instruments, use non-sharp instruments, do your lateralization or medialization as gently as possible. And this is the cautery which has been curved, which is being used. We make rescue flaps in every case, so that we know the location of the nasopalatine artery, and you will not lose it if you want to develop into the proper flap later on. We do about 1 centimeter exposure, and then we leave it there because that bone is going to go anyway. Once that is done, then we are removing part of that bone to make it into a binostril approach, and then you are onto the sella. I have not shown you the sphenoid opening. So this is when the sphenoid opening is being done. As I told you, you first go down, then you see the lower margin, then you go to one lateral margin, other lateral margin, and then go to the top. If you want to open the plenum, you can go a little further. Now we have started drilling this sellar floor. You can see this is the paraclaval carotid becoming the cavernous carotid here, and this septum is you can see very nicely on the left carotid. So I try to do it like a paintbrush, do a C on both the sides of carotid, because that is how you can maximize your opening, and do the same at the top. So 12 o'clock, 6 o'clock, 9 o'clock, once you have identified, then you know what to do. Initial part of the drilling you can do with a proper cutting burr, but later part of the dissection, when you know that you have thinned the bone enough, you should use the diamond drill, striker. And now actually most companies have made available what is called a coarse diamond drill, which is probably the most useful drill which you find in these kind of surgeries. Once you have done this, you just make sure that you have gone lateral enough. As you have seen that the tumor was going into the left lateral sinus, so we have opened a little bit more on the left side. And now I have started opening, going into the tumor. So I start with the bottom. Once I start with the bottom, I would remove tumor from like 8 o'clock to 4 o'clock to begin with. Once I have made enough space, then I am trying to now dissect the tumor out from the cavernous sinus. Once I have got enough space, I try to go then extra capsular, as you call it. I mean, most people believe there is no capsule in the pituitary tumor. So whatever that layer is, which you can easily separate from the cavernous sinus wall, I would first like to go to area which has where the tumor is not going into the cavernous sinus. The other decision making factor is where is the normal pituitary. So I would like to go away from the side of the normal pituitary when I initially start dissecting. Most of the times the pituitary is displaced back and towards one side of the cavernous sinus wall. So this is being cleared here. We have cleared up the cavernous sinus wall on one side. We have cleared up the tumor at the bottom right up to the clivus, and now we are trying to go to the top and the opposite side. So opposite side first, you can see some normal gland here, and we have been able to create a plane there. I use patty generously to make sure that the diaphragm doesn't fall, or if I have any doubt that I am probably dealing with normal pituitary. Usually normal pituitary does not come into suction, but you may occasionally have to protect it. Make sure that you do not unnecessarily curate too much. Be gentle. As you can see, I am using the blunt end of the curate and not the sharp end of the curate while doing this, and I always like to go from front to back rather than coming from back to front, where you can damage structures. Now we are trying to remove tumor from 2 o'clock, 1 o'clock area, which is difficult, and as you can see that we are holding the diaphragm up on one side and trying to get into that plane of dissection. We are doing the same now on the left side after clearing the right side, or the left side was cleared first and now the right side. And here I am using actually upward suction. So you need different kinds of suction. All of them should be graduated. All of them are either keyhole or three-hole suctions. I think all neurosurgeons are aware of this, and that is one of the most important things to make sure that you do not unnecessarily damage either the normal pituitary or the cavernous sinus wall. And you have to dissect properly in these planes. As you can see, I am holding the diaphragm up with the suction and with the second suction. So this two suction method is the most common way we remove most of the large tumors. Now the tumor from this side is falling down further, and this is another thing. Once you have cleared up enough on both the lateral walls, the tumor in the center starts falling and makes it easier for you to remove this tumor. And wherever I am not comfortable, I am still using the back end of the curate to make sure that I am getting a plane of dissection. And you can see that the plane of dissection is on this side, is between the normal pituitary and the tumor, and not the direct cavernous sinus wall. You can see that the diaphragm has started falling down as we have removed that bit of tumor. And now once the patty comes out, you will be able to see the same on this side where the diaphragm is thinned out further. So virtually whole of the tumor is out, but we would like to put a patty there. We would like to examine all these areas. We would like to see, I have actually what do you call it, layered a little bit of normal pituitary here while trying to remove the tumor radically. Sometimes that can happen, but try to preserve it as much as possible. It looks more orange and it looks more vascular than rest of the tumor. As you can see, there is a clear difference seen in the tumor fragment and the normal pituitary here. We pack for a minute after you have removed the tumor, and once we pack, we again look at all the walls separately. You can see that the tumor has been completely cleared up from both the cavernous sinus walls. Tumor has been cleared up from the top of the diaphragm. These two corners are the most vital, where you lose some part of the tumor. So important is to take those corners first before you come into the middle. Whenever there is a waist around the tumor, you can occasionally leave this central part of the tumor behind if you are not very careful, because the diaphragm, once it falls down, especially in front, it makes it impossible for you to see. So don't take out the front of the tumor, and that is the main purpose of keeping this kind of a flap. Most people will ask, why don't you cut like a cross? This is one of my major reasons. I like to keep a flap on the top, which allows me to do all this and allows me to retract this without causing direct injury to the thinned out diaphragm. I am just at the end of this. I'm sorry if I am exceeding time. 2 more minutes is what I need, and you can see now the center of the diaphragm, which is completely falling. When you see this kind of a diaphragm, you know for sure that you have removed your tumor completely. And then we are making sure that the ends of the bone are cut properly. We are putting the flaps back in place. If there is no CSF leak, we will not put any flap over there. We just put a layer of gel foam and come out. Depending on how much mucosal dissection has occurred, you would probably leave either a Merocell pack or you may not leave it. In most patients, we do not leave it unless there is a mucosal injury. There is no point in continue to packing, and that is the end of the procedure. So thank you, and I'm happy to take any questions either now or during the dissection.
Asymptomatic case in autopsies they said. We are doing
Autopsy is 14%, yes. That is the figure which American paper has quoted.
but it may be too much because we are doing good thing.
No, in fact, if you have seen the next sentence after that was, all the patients, if you have just seen about 18,000 scans they have shown, the prevalence of pituitary tumor is 22% on MRIs. It's a very, very high percentage, and I do not know of any study from India. Dr. Suri can tell us if there is any, but the approximate figure is at least 1 in 10 people is harboring pituitary tumor as of now.
As ENT surgeon, we are doing many MRIs, but nowhere they are mentioning any asymptomatic cyst in pituitary.
Can I just know who's speaking, please?
Yeah,
Ah.
we are doing many MRIs for different reasons.
Yeah. So, are you a radiologist or a neurosurgeon?
I am ENT surgeon.
Right. I think in ENT, most of the times the suprasellar region may not be properly examined. But if you are doing scans, please ask your radiologist. I'm just hoping that we have a study to show from India, but it is extremely common. In my outpatients, I operate less than 50% of pituitary tumors that I see. So almost 50% are found either incidentally or they are asymptomatic. It's very common. I cannot give you a figure, but I can tell you as many patients I have operated, almost the same number of patients I have not operated.
I have one question. If a tumor is quite firm and very vascular, as you are using two suction technique, soft tumor is good to remove and they come out very easily. So if it is firm and vascular, what is your technique for it?
So actually tomorrow during my talk, I will show you two cases of
Sure.
firm tumors, one vascular and one firm tumor. I have not kept it for today, but I have a simple answer to this question. This used to be my biggest bugbear when I was operating, and I don't think I have still conquered that area, but it has become much easier by two techniques. One technique is rather than using two suction technique, you use dissector in one hand, like you do for any microsurgery, and second hand still holds the suction like we are just used to it. And you can do a dissection around the tumor. You need to take out, maybe like if the tumor is about 3 centimeters, you need to core out the center half to 1 centimeter, either with scissors or whatever is your comfort level, or even knife, and then try to go for a what is called extracapsular removal. I think today for a firm or a vascular tumor, the best way to remove the tumor is extracapsular. Near the diaphragm it becomes difficult, but if you are careful, you can sometimes preserve the diaphragm even in those tumors, and if not, then we have better ways of repairing these days. So I think extracapsular removal is the simple answer.
Thank you, sir.
And actually, these two tumors are never together. It will be very fleshy and very firm, but less vascular. But it will be something which can be a bit, but not very soft, but fleshy, but very vascular. And absolutely, Debajari is absolutely right. I think that is what I have found in my hands is partial and coring out the tumor with relative the blood loss, and then putting a gel foam and some Flosil in the cavity, and then going around the tumor, that is extracapsular. That really helps. That really helps. But if it's going in the cavernous sinus, I do that portion later. So it is better to do that.
Thank you.
Can I ask one question? When you consider extended approach for pituitary adenomas?
So we are becoming more and more liberal as we are doing more cases. Earlier, I did not want to drill plenum in most of the pituitary tumors, but today, if I have a tumor which has a huge suprasellar extension, or if the tumor direction is towards the anterior cranial fossa, I would like to take out tuberculum and maybe 1 centimeter of plenum. I will not open the dura there unless it is absolutely necessary, but just by removing the bone, it becomes easier to maneuver.
I think we go to the next talk by Dr. Prakash Nair. He is presenting virtually. Uh, he is a recorded talk, isn't it? Start.
A very good morning to all of you. I thank the organizers for giving me this opportunity to speak on the extended approaches to the skull base. I also regret not being present physically due to unavoidable circumstances. So I shall go on to discuss my first case, which is a craniopharyngioma operated multiple times with the residual cystic and the solid component located in the suprasellar cistern and extending into the interpeduncular cistern. The basic exposure consists of dural exposure up to the limbus and dural opening extending onto both the optic nerves. The technique involves meticulous microsurgical dissection. In this particular case, one must remember that the superior hypophyseal artery complex is likely to be shifted anteriorly, which means that the surgeon is likely to encounter the superior hypophyseal artery system first. One must also remember that the superior hypophyseal artery has three branches, and the branch that supplies the diaphragm can be divided, and this helps us mobilize the main trunk that supplies the optic nerve. Once the artery has been moved out of the way, one can go on to decompress the tumor. Decompression of the cyst gives some more room to not just manipulate the tumor but also dissect it from the adjacent neurovascular structures. The next important neurovascular structure that one will encounter are the branches that arise from the PCOM. Now, in this particular case, one reason for this recurrence was the presence of the solid calcified component just beneath the optic nerve. And this is an area that is not easily accessible through the transcranial route. However, through the endonasal route, one not just gets very good access to this particular region, but is also able to dissect this particular region very nicely. As one dissects into the interpeduncular cistern, one can observe the basilar artery, and at this point of time I start to now slowly mobilize the hard calcified mass present beneath the optic nerve. The dissection in this particular case follows the principle of microsurgical dissection, where meticulous management of both the vascularity as well as of the neural structures is required. At this point of time, we open into the third ventricle, and the attachment of this calcified part against the dura is divided. The attachment is tenacious, and one needs to be very patient as one starts to dissect this part of the tumor. You must also remember that the PCOM is likely to run just beneath this calcified part and is likely to come into view as this dissection progresses. After painstaking dissection, this calcification is finally free to be removed from the surgical cavity. In my view, one of the most important advantages that the endoscopic intranasal approach provides a surgeon in managing a craniopharyngioma is this unique visualization of the interpeduncular cistern and the third ventricle. We are able to not just see these structures very clearly, but also dissect them under direct vision. Attachment to the hypothalamus can actually be visualized and separated in very meticulous fashion. This is often not possible when one approaches the third ventricle through the pterional route, where the upper part of the third ventricle is not easily visualized. It is also very important to note that the mammillary bodies must be kept in mind when the dissection at this particular part is carried out. This is because an injury to the mammillary body can lead to cognitive dysfunction as well as significant hypothalamic obesity. In this particular manner, the entire calcified part is removed and the walls of the third ventricle, the foramen of Monro, is visualized. One can also see the third nerve on the right side, the PCOM, and the superior cerebellar artery. One can see the optic nerve, the left-sided internal carotid artery, and the PCOM. So these are the post-operative images showing a gross total resection. My next case is of a meningioma with invasion of the optic canal on the medial aspect on both sides. This patient had presented with significant loss of vision and also had partial involvement of the ACA complex. Now, the exposure is slightly different in this particular case. The exposure extends much more anteriorly onto the planum, and the dura is first opened and the anterior intercavernous sinus is coagulated, and the tumor consistency is soft. The initial decompression can be done with suction, and the dural opening can be extended towards the optic nerves bilaterally. As the tumor decompression proceeds, one can also start to appreciate the optic chiasm located at the back. At this point of time, we've also started to visualize the pituitary stalk and the ACA complex with both the A2s and the ACOMs that come into view. It's more convenient to divide the tumor and roll out parts of the tumor individually. So first, on the right side, the tumor slowly dissected and removed. This gives us the ability to decompress the optic nerve. Here, we need to be a little bit more careful while detaching the tumor from the A1. And here the tumor is again rolled out. Now, one must remember that the long-term outcomes depend upon the clearance of the tumor within the optic canal. And one of the advantages that the endoscopic approach gives you is the ability to completely decompress the optic canals very early on in the procedure. This is also possibly the only manner in which this can be done on both sides. So this is using a number 1 upcut to remove the dura over the optic nerve. So at this point of time, one can visualize the chiasm, the pituitary stalk, the optic nerve, and reconstruction is performed in a standard multi-layered technique using fat, fascia, and a large vascularized nasoseptal flap. My next case is a petroclival chondrosarcoma extending from the posterior clinoid on the left side to nearly the petrous apex. The epicenter of the tumor in this particular case is the petroclival synchondrosis. There is also partial involvement of the cavernous sinus. The endoscopic endonasal approach for these cases provides a very direct trajectory to approaching the tumor. The key The key surgical technique in this particular case is to mobilize the internal carotid artery all the way from the foramen lacerum to the cavernous sinus. One important landmark that one must identify is the Widin nerve. The Widin nerve can be used to trace the genu of the internal carotid artery, and this was an invaluable landmark while we are drilling the ventral skull base. Even though the tumor is calcified, because of the direct trajectory, one can slowly mobilize the tumor. We also perform a partial extradural pituitary transposition, which allows the surgical corridor to be widened, and these large bits of calcifications are slowly mobilized and removed. Adequate surgical resection involves removal of the posterior clinoids, and very often one needs to use other adjuncts like a bone QSA or a drill to be able to remove the hard calcified pieces of bone. But with a little bit of perseverance, one can remove the hard calcified pieces completely. There's also a bit of a soft tissue matrix that we identify around the tumor, which is partially resected. The entire procedure was carried out under neuromonitoring. We further drill the clivus to obtain negative margins, and this is also very important because in chondrosarcomas the most important predictor for long-term outcomes is a negative bony margin. So these are the post-operative images that show near total resection of the tumor. My last case is a view into the coronal plane approach to the endonasal corridor. This particular case is that of a Meckel's cave dermoid in a patient who had presented with significant trigeminal neuropathy. And in this particular case, because of this broad corridor anterior to the internal carotid artery, the endonasal approach gives a very direct route to excising this particular tumor. Since this involves resection of the pterygoid wedge on the right side, we perform a middle turbinectomy and an middle ethmoidectomy. We then go on to perform a maxillary antrostomy and identify the sphenopalatine foramen and the sphenopalatine artery. Once the sphenopalatine artery has been identified, we slowly skeletonize it and coagulate and cut this vessel. This gives us exposure to the pterygopalatine ganglion. We also perform a septectomy to make one broad corridor to facilitate mobilization of instruments in this particular space. Now, one of the key concepts in dealing with lesions that occupy the coronal plane, this is the sphenopalatine artery which is being coagulated and cut. As I was saying earlier, one of the key concepts to approaching tumors in the coronal plane is to identify and drill the pterygoid wedge. This gives us exposure to the Meckel's cave and also allows exposure of the Widin nerve. The median nerve in turn leads the neurosurgeon towards the internal carotid artery and is a very important landmark for avoiding vascular injuries during the surgical procedure. Following this, the ICA and the bone lateral to the ICA is mobilized. Bony exposure is of utmost importance because unless the bony margins have been removed, it's very difficult to put instruments into this particular region. One can also appreciate the stump of the median nerve. So we use the Doppler to first locate the internal carotid artery, and we also use neuromonitoring to identify the location of the sixth nerve, which might be pushed anteriorly in very many of these cases. The dural opening is tailored by where we think the sixth nerve lies. So we first start to open the dura just inferior and anterior to where we get the impulses of the sixth nerve. And we keep our exposure low to avoid damage to the sixth nerve during the resection of this particular tumor. Once the dura is opened, we can appreciate hemostatic matrices, which is used for getting hemostasis within the Meckel's cave and the cavernous sinus. One can appreciate hair and this waxy cheesy material which is characteristic of the dermoid. Decompression is performed in piecemeal fashion using a combination of dissectors and suction. The dissection is carried out towards the temporal dura as well as to the posterior fossa dura. We occasionally encounter bleeding from the venous plexuses, and this can be managed by injecting hemostatic matrices. As we take our dissection towards the posterior fossa, we will encounter CSF, which will tell us that the posterior fossa has been reached. One can appreciate a gush of CSF and the fifth nerve behind the arachnoid. So at the end of the surgical procedure, one can appreciate the gastrial ganglion, the temporal dura. And these are the post-operative images which show decompression of the fifth nerve at the end of the procedure, as well as complete resection of the tumor on diffusion weighted imaging. So these are a set of cases that I have presented which broadly encompass the various procedures that might be carried out using the extended endonasal approach. This is by no means a very exhaustive lecture. However, once again, I thank everyone for a patient hearing, and thank you very much.
Thank you, Dr. Nair. Thank you for this presentation. Now I request Dr. Amit Goyal for his presentation, endoscopic approaches.
A very good morning to all of you. I thank the organizers for giving me this opportunity to speak.
Alok will be able to tell better, I'm sure. You do not want to break it completely.
Okay.
Many a times.
No, because I learned it from Peter Schaefer, who is because we had a long collaboration with Martin Wittag, and what I do is we go for the bigger nose, because according to them, 95% of patients have some nasal deviation. And plus, I work with Dr. Alok also very closely, and then we go for the more capacious, never always the right side, and we do a posterior septostomy on the more capacious side. So automatically, we undeviate the deviated septum and then go. So we
bullosa, you can.
yeah, we can do that. But can you also give your...
Well, it depends on the space you need and the space you have. Sometimes it's going to be very tight, and you just might have a very narrow nose and bulky turbinates, and other times you might have very shrunken turbinates and a wide nose. So if you need to, you should. There's no issue at all in dissecting. The only issue is that the sphenopalatine artery, as it comes out from the posterior end of the middle turbinate or below the middle turbinate, is bound to be a very vascular area which will bleed. So nice to do good dissection and good bipolar before you actually do cutting of the middle turbinate.
And you can do a partial dissection on you split on the incision and you take out the bone of that, or you just whenever we require we do a complete middle turbinectomy, but
Radial half of the bone
middle
is
half.
taken away.
Okay.
Usually there is a air cavity.
Yeah.
Endoscopic approach for optic nerve sheath fenestration, Dr. Koil. Thank you.
Good morning all. Let me thank Dr.
Can we have
Rajni
lights off?
for this opportunity. It's after long that I've been a part of skull-based conference, and it's good to see physical mode being happening again. So Dr. Dev Pujari, actually he reminded me of two things in his lecture. One was that during microscopic pituitary, Siam was used to, the suction used to be put, and Siam, under Siam they used to locate sphenoid and enter it. So from that era we have come quite far away. And secondly, reminded me of Dr. Nishish Shah, a fantastic ENT surgeons, and in my early stages of career I have attended their couple of workshops, and after that Dr. Thakkar and Dr. Satish, they have been pivotal for my interest in skull-based surgery. So I will be very brief and mostly on the technical pulse. I have been given a lecture which is not very commonly being done. It's optic nerve sheath fenestration, and there are indications, but the number of patients are not very huge at most of the centers. So I have no conflicts of interest, and by definition it's a surgical procedure in which one or more parallel incisions are given in the optic nerve sheath, which are actually meninges, to decompress the pressure which is built up in the subarachnoid space. So initially it was described way back in 1872 for pseudotumor cerebri causing vision loss. After that, not much interest was there. Then in 1964 in rhesus monkeys it was used again. Then transconjunctival approaches were described, and later orbitotomy approaches were described for this procedure. So sorry. So just to brief anatomy, all of us are aware that actually it's not a nerve, it's a part of the central nervous system which carries all the meninges along with the subarachnoid space along with it in the optic canal. So it has four parts: a very small optic nerve head, intraorbital optic nerve which is a bit tortuous in course, so a little bit amount of stretching it can withstand, but after that it can't withstand any more. This is the narrowest part of the bony part, the intracanalicular part, and this is the area which is our area of interest while doing this procedure. And then comes the intracranial part. So the nerve sheath, all the layers, they come along with the optic nerve, and this subarachnoid space also comes into the optic nerve. So that's why we take this anatomy for use of decompression of increased intracranial pressure, increased CS of pressure. So as we can see here, if we see from the intracranial side, the optic canal, it opens, and there is an optic strut which is a part of lesser wing of sphenoid. So there are two main things which are in nearby thing in the vicinity of this optic canal. One is this supraorbital fissure which faces entirely in the different direction, and one is the foramen lacerum from which the carotid comes up, and it is the clinoid part of carotid which is in close proximity with the optic canal. So this anatomy we need to, and when we see endoscopically this entire thing, what we can see here, the optic canal, the carotid part, and there is a this carotico-optic recess. So this OCR, it is sometimes very prominent, sometimes not much prominent. It's a aerated strut, and so we need to be careful while operating on optic nerve. Another important point what we can see here is that the lamina papyracea is very thin, The optic canal bone is also not very thick, but there is an optic tubercle, which is the thickest part, from where the transition from ethmoid to sphenoid occurs. And this is the area where we need to actually drill. By simple instrumentation, it's very difficult to break this area, and we may damage more to the optic nerve if we try to do that. Another structure which is of concern is this ophthalmic artery. It is in the lateral part, mostly in the intracranial part, but when it comes and intraorbital region, it crosses the it crosses optic nerve and comes to the medial part. So this from lateral to medial may occur anywhere, and this is not a rule. It may sometimes found inferomedial also in the optic canal area. So we have to be careful about this structure when we are operating. So this is a small, this will run in loop. So try to localize it's a CT angio. So try to see how this ophthalmic artery actually, first try to see this axial section. What we can see here, superiorly, running superiorly and going medially. From lateral to medial transition occurring in the axial section. Again, you can see this particular. We can see very clearly. And what we can see in this coronal cuts, that it is actually a branch of ICA. So what we can see, this dot, it's going in the laterally, inferolaterally, and merging with the carotid. So CT angio can give us some anatomical location, or even MRI can also give us anatomical location of the ophthalmic artery when we are looking for this procedure. Another thing, the sphenoid anatomy, it has been already described many salient points, but what concerns us is the type of classification given by Delano and its relation with the sphenoid sinus. So in type 1 Delano, it's difficult to locate optic nerve because it is going just adjacent to the sphenoid sinus. In type 2, it is causing some indentation. In type 3, it's almost there is a very deep OCR what we can see, and we can very clearly see. Now many times it has happened that it is actually running in the roof of sphenoid. We can see radiologically, it's like hanging like a mesentery. Without any bone also you may find it sometimes. So you have to be very careful, especially if we are stripping the mucosa and the sphenoid sinus. That radiological pre-operative radiological evaluation is of paramount importance. And the type 4, where it's in relation with the ethmoid as well as sphenoid, and this is the most dangerous condition, because we even while doing ethmoidectomy also we might tend to damage this. So the rationale for optic nerve sheath fenestration is that it's serves as a CSF conduit between the brain and eye, and pathologies that involve the contents of cranium and cause increased ICP, intracranial pressure, like masses or trauma or inflammatory diseases that can impact optic nerve head. And if so that's why we have papilledema as well as decreased vision. So when it is transmitted, it head edema ensues, and it's a surgical technique where we are reducing that CSF pressure, so thereby relieving the pressure on the optic nerve head. So it's a purely mechanical perspective what we are looking at here. Indications, there are certain pathologies where simple decompression of optic nerve will suffice, and there are so the for fenestration, it's the main indication is of this your for fenestration, it's only elevated intracranial pressure, mostly after idiopathic intracranial hypertension. And there are conditions where we can do only decompression. So like in traumatic cases or neoplastic cases, simple decompression sometimes may suffice. Another indication for fenestration, very important indication, is post-traumatic hematoma in the optic nerve sheath. So that certainly has to be evacuated if we want to resolve the vision loss. With regards to contraindications, it should not be performed in patients on anticoagulants, because orbital hematoma is more detrimental, and if any CNS infection is there, then definitely it should be avoided. And if there is any mild or moderate vision loss, then you can wait with the conservative management. It is expected to reverse, and simple headache after this pseudotumor cerebri, that's also not an indication for this optic nerve sheath decompression. So surgical techniques, like we have seen initially, they were open approaches, then transconjunctival. Now totally it is done, mostly cases transnasal. And when we talk about transnasal corridors, to approach sphenoids, there are 3 corridors: lateral corridor, intermediate corridor, and medial corridor. So if you are doing only unilateral optic nerve decompression, then lateral corridor suffices. We can do a complete ethmoidectomy, we can remove the lamina papyracea, and we can decompress the entire optic nerve. But if we are doing it as a part of some other sphenoid or intracranial pathology where we need to open up the entire sphenoid, then it can be done by medial approach also, but in that case also the ethmoidectomy is an integral part. So as we can see here, we have to do a complete ethmoidectomy along, and this optic tubercle has to be drilled, because you can't just take it out by simple pulling or maybe fracturing out. And then the thin bone is removed in the entire area, and then fenestration is done. Fenestration is done mostly, if it is needed, then in the inferomedial part, because that is the safest part, or maybe a little bit medial or superior part. But should not try to go even laterally, even a bit. Stay in the middle part only. So decompression versus nerve sheath fenestration. Decompression at least more than 180 degree as we decompress for any nerve, that's a dictum. Simple opening the optic nerve canal will not serve your purpose. So with regards to radiology, we have discussed instrumentation, that is very important. We should have we should have blunt and stout instruments to remove the bone, but as we go near the optic tubercle, the bone starts becoming thick. So we tend to put more and more pressure. But remember, when we are trying to put more pressure, we might put more pressure on the optic nerve. So in that area, use a drill, maybe a diamond drill. But again, if you are using a drill, then irrigation is very important, because even heat can damage the optic nerve further. And the technique, I'll try to demonstrate if time permits during the cadaver dissection. And the learning curve certainly need to be very well aware, very well comfortable with the sinus anatomy for this particular thing. As with any other procedure, there are certain complications associated. They may lead to very minor complications to catastrophic, including the vision loss, complete vision loss, orbital hemorrhage, infection, or maybe apex syndrome. Muscles may be damaged if we are not careful in removing the lamina papyracea. So it's a relatively safe and effective surgical procedure in patients with vision loss due to papilledema. Preoperative imaging, classification of the nerve, and preoperative planning, that's of paramount importance. And I think most of you are seeing the scans on computer nowadays. So if those who are not seeing the scans on computer, please develop that habit and read the scans yourself. Don't depend on the radiologist reporting always. And level 1 evidence is still lacking on the data about vision outcome after, though there are series available which have documented the improvement in vision, but level 1 evidence is still lacking. So thanks for your patience listening. Any questions, I'll be happy to answer, or maybe we can discuss during cadaver dissection.
Thank you very much, Dr. Goel. Any questions or comments?
Thank you.
Now I would like to invite our next speaker, Dr. Vidhu Sharma, endoscopic approach to CSF rhinorrhea.
Very good morning to all of you, and first of all I would like to thank the organizers for presenting this privilege to me. Today I'll be talking about the endoscopic approach to CSF rhinorrhea. I would like to just cover the salient aspects and focusing on the reconstruction options and the surgical techniques involved. Also some special considerations, some special cases I would like to highlight. So CSF rhinorrhea was reported, the first case was reported as long back as the 17th century, but it wasn't till the early 20th century that Dandy did the first successful repair by a bifrontal craniotomy with a facial lata graft. And now, over the years, since the 1980s and 90s, purely endoscopic transnasal approaches have become popular, with success rates of almost more than 95% in most cases. So we all know the etiology is classified as traumatic and non-traumatic. Accidental still form the major chunk of patients. 80% of the patients usually present within 2 days to 3 months of trauma. And certain set of patients may develop during iatrogenic injury, during neurosurgical or sinonasal surgeries. So what is important to note here is that based on the etiology, our approach to the patient might differ. For example, a patient who has extensive head trauma and is going for a neurosurgical intervention, an open approach is a better option rather than waiting for conservative management and then going for an endonasal approach. Also, most of the trauma patients, they are relieved by conservative management itself, whereas any intra-op injury has to be repaired there and then on table itself. There is no role of conservative management. And a significant set of patients have raised ICP and empty sella syndrome on radiology, BIH. These are certain situations where the patient might not have any other symptoms and they might be difficult to diagnose. So what goes wrong is that for CSF to present in the neck, it's not only a defect, but there has to be a defect involving the entire arachnoid dura, PNS mucosa and the intervening bone. And the pressure gradient of the CSF across this defect will present as rhinorrhea. So depending on whether it is a high flow or low flow leak, our surgical approach again differs. So since the entire skull base is barely submillimetric in thickness at certain areas, so the entire skull base is prone to develop defects. So it can be anywhere from the cribriform plate, the roof of the ethmoid, the sphenoid sinus or the posterior wall of the frontal sinus. But the most challenging and important sites I have mentioned here are the lateral lamina of the cribriform plate, which is this area. It is less than 0.1 millimeters in thickness. So the longer it is, the weaker it becomes, and in patients with raised ICP like VIH patients, these areas they become dehiscent and the patient may have meningoceles or meningoencephaloceles along with them. Another challenging area for the surgeon who is approaching it transnasally, transendoscopically is the lateral recess of the sphenoid sinus. So a persistent craniopharyngeal canal or the Sternberg canal, which lies in the inferolateral wall of the lateral recess, if there is a dehiscence here, it becomes difficult to approach surgically. I'll be sharing a video in some time of such a patient. So preoperatively, we all know the role of history is important. Some patients might present purely with recurrent meningitis without any history of trauma or without any history suggestive of rhinorrhea. Confirming the leak and localizing the defect is the most important aspect, because unless the defect is localized, it cannot be repaired. And the outcomes are severely diminished if we are not able to localize the defect and we just do a blanket repair. So certain patients who are having active leak, we might see it on diagnostic nasal endoscopy. Otherwise, beta-2 transferrin and beta-trace protein are highly sensitive and specific for CSF. To localize, we have many invasive as well as non-invasive modalities. So amongst the invasive ones, as we all know, CT cysternography and intrathecal fluorescein with endoscopy have been used. Even though fluorescein is very popular for localizing the defect, intrathecally it is administered and the patient is placed in a head-low position and we wait for a certain period of time, and endoscopically we can identify it. So this technique can be used preoperatively also or intraoperatively also if the leak cannot be identified. However, since the use of fluorescein is not US FDA approved for this particular indication, it is popular. But a better approach is MR cysternography because it is non-invasive. Without the use of fluorescein also, it helps to identify many of defect areas. So coming to the important aspect, that is the surgical principles. As I said, the foremost thing is to identify the site of defect. Unless we identify the site of defect, the outcome is not going to be adequate for the patient. So once we have identified it, preparing the defect site is important. So whenever we see the defect, around 5 millimeters of nasal mucosa surrounding it has to be denuded so that the graft can stay there. Merely placing a graft will not work. If the patient has an additional meningoencephalocele, so using a bipolar cautery or a coblation, we have to ablate starting from the neck of the meningoencephalocele. The entire sac has to be removed. We should not attempt to pull or push the brain contents inside or outside. We simply have to remove them. And the facial graft is to be placed intracranially. I'll be discussing it later on also. No mucosal graft has to be placed intracranially because if it migrates, it can later on cause mucocele formation. So whenever you're placing a free mucosal graft as onlay, So the mucosal aspect of the graft has to face the sinus cavity and not intracranially. Also, the CSF pressure itself serves to hold the graft in place. So the use of lumbar drains is a bit controversial. If it is a low flow leak and we have put a lumbar drain, then the CSF pressure will be further lowered and the graft will migrate away from the repair site. So in certain exceptions like high pressure leaks or when the surgeon is not very confident of the repair, lumbar drains still have a role, but not for routinely all cases. So this is a multi-layer repair that has been done. Fat globule has been placed and then there is an extradural inlay temporalis fascia or fascia graft is placed. Then another onlay fascia is placed which can be supported by vascularized pedicled flaps in case of high leaks. And middle turbinate, superior turbinate resection is not routinely needed. It all depends on the side that we have to approach. If we have to go to the lateral recess, then anterior posterior ethmoidectomy, a standard sphenoidotomy, and a transpterygoid approach is needed. If we are approaching the cribriform plate or the ethmoidal roof, then we might or might not need to resect these structures. So Wormold had described bath plug technique for small leaks, that is around less than 5 millimeters, and it is a very popular and successful technique. So this is the defect that has been identified. Fat is taken, it can be taken from the ear lobule or the abdomen or the thigh. The length of the graft that is taken is around 1.5 to 2 centimeters, while the diameter is supposed to be same as the diameter of the defect size. A vicryl suture is run through the entire lobule of fat, and gently using a ball probe, we push it inside the defect. Care has to be taken care that only a few millimeters is to be pushed at a time, because there is high chance of injury to the intracranial structures, especially in traumatic cases or where the dura is adherent in patients with meningoencephaloceles. If the dura is adherent to the bone surrounding it and we are pushing the fat with too much force, we can cause injury, and the vessels which are in relation to the meningoencephalocele might also bleed. So once this fat is gently pushed inside, this thread is used and we tug it gently so that this fat is acting like a bath plug. So it has sealed the defect entirely. A little bit fat will prolapse in the nasal cavity and the rest will act as a seal. Now over this thread we can use a free mucosal graft. Any septal mucosa can be used. It is threaded over the vicryl and it supports the repair. So a general principle to follow is that suppose there is a nitrogenic injury but there is no active leak, a simple mucosal graft can suffice. If it's a low flow leak, then multi-layer repair is best. We can use autograft with or without synthetic dural grafts. And if it is a high flow leak, then in addition to this, vascularized tissue flaps have increased the outcomes to more than 95%, as different studies have suggested. So the reconstruction options are free grafts and vascularized flaps. Free grafts, as we know, they are detached from the donor site, so they don't have the vascularity, but they can be used as overlay grafts, especially when there is a small defect, especially like the cribriform area, or they can be used as in combination when we are using a sandwich technique or a multiple layer technique. So this is example of a small defect being repaired in the cribriform area with the overlay technique. So materials can be fascia lata, temporalis fascia. We can use mucopericordium, mucoperiosteum. Bone and cartilage, though they have been defined by various authors, but it is not advocated nowadays because risk of displacement is also there, and to achieve a good seal, multiple layers of fascia, multiple layers of collagen are which provide better chances of repair, successful repair, rather than using just bone and cartilage. Even heterologous and synthetic materials are being used nowadays. So one important aspect is vascularized flaps, because these are important for any skull-based reconstruction. And depending on the size of the flap we need, we can use intranasal or extranasal flaps. The most important one that I'll be discussing is the Haddad-Basegesticki flap based on the posterior septal branch of the sphenopalatine artery. Amongst the extranasal ones, pericranial, temporoparietal fascia and palatal flaps have been described. So this is the workhorse of reconstruction in extended endonasal skull-based surgery and has improved outcomes by many times. I'll be showing a small video of this. I'll be discussing 3 small cases. One was a 38-year-old lady who presented with intermittent watery nasal discharge from the right side, a classical history of CSF rhinorrhea, increasing on bending forwards, not sniffable, intermittent headache for 10 years, and a history of trauma 10 years back. After all of the investigations, the defect was identified as a 9 mm defect in right cribriform plate along with herniation of the brain contents into the nasal cavity. So this is the right nasal cavity, this is the septum, the middle turbinate, the inferior turbinate. So after infiltration and decongestion, The meningoencephalocele was identified. And here we are attacking the neck using a coblation wand. So the first point is to cauterize or coblate the meningoencephalocele entirely. So once the sac was removed, we identified the defect, and the surrounding nasal mucosa will be prepared using a bipolar forceps, bipolar cautery. So this is again using coblation, we are preparing the nasal mucosa. So now this is the site of the defect, and the movements have to be very gentle. There is no probing, only small gentle movements with a ball probe is being used. We can see the defect site along with the dural pulsations. So again, with gentle movements, fat is placed inside. I'm sorry, something is wrong with the cursor, I think. So once fat is placed, we will place an overlay, one underlay fascia and then an overlay fascia. So this is fascia lata. 2 strips are used and one overlay in the end. Then we have used tissue glue and packed the nasal cavity with Surgicel over the defect site, and later on a Mirocell is placed to support the repair side. Another case was a 36-year-old gentleman who had isolated history of CSF rhinorrhea. He was a diabetic already on treatment. But what was important in this case was that even though CSF was confirmed using beta-2 transferrin, there was no active leak on endoscopy. Radiology played an important role because this patient actually had a pituitary macroadenoma, and the sole presentation was CSF rhinorrhea. So it was incidentally detected. The patient was put on cabergoline, a neurosurgical and endocrinology consultation was taken for the management, and the patient was, the defect was repaired using a head-art flap. The patient was doing well after that. Now, one of the most challenging sites to tackle was the Sternberg's canal, as I discussed, in the lateral wall of the sphenoid sinus. The difficulty is in approaching this, so we have to go through the pterygoid. So it is a trans-pterygoid approach which is described to tackle this area. So this patient again had a spontaneous CSF leak, which was, the site was diagnosed on CT and MR cysternography. This is a small video showing the head-art flap that was taken. So the initial incision starts just below the level of the sphenoid ostium, and this is the inferior incision. The incision from the sphenoid ostium is curved upwards at the level of the middle turbinate. It can go as high as the olfactory fossa, as anterior as the nasal vestibule, and inferiorly along the floor. So for a bigger defect, the entire floor of the nasal cavity can be taken up into the flap. Now once the flap is elevated, it is parked into the nasopharynx. Then the sphenoidotomy has already been done, but to approach the lateral recess, drilling is done. This is the floor of the sphenoid sinus. To approach laterally, we are drilling in the pterygoid area, and after reaching the defect site, here is the defect site with the accompanying encephalocele. Again, the repair was done in a similar manner following the previous surgical principles. One interesting and confusing or misleading case was that of a 1-year-old male child who presented with history of multiple episodes of meningitis, and the parents complained that since 6 months of age, he's having clear watery discharge from both nasal cavities. So there was no history of trauma, but the child had delayed milestones which could be attributed to the meningitis part. So the initial impression was that maybe it is recurrent meningitis because of CSF rhinorrhea. So an HRCT PNS was done. Now during the imaging, the radiologist could not find any defect. So in pediatric patients, since the entire skull base is mainly cartilaginous, so finding the defect can be confusing. So what they did was they put the child in a head down position. They literally tilted the child upside down, and then they could see some trickling through the eustachian tube. So they took sections of the temporal bone, and ultimately they found after CT and MRI that the child had an inner ear anomaly, a bilateral incomplete partition 1 malformation in the left IAC, and CSF was collecting through the eustachian tube into the nasal cavity. So it was basically CSF otorhinorrhea, which could have been misdiagnosed and could have been explored without having looked at the temporal bones. So we did a left radical mastectomy with CSF leak repair, and a few months later, right-sided cochlear implantation was done for this child, and he's doing well. So a variety of cases We also had the experience with a variety of cases, children as young as 5 months old, post-traumatic cases, patients with BIH, spontaneous CSF rhinorrhea, and during the COVID-associated mucormycosis epidemic, we found lots of patients with extensive skull-base erosion, which made them more prone even to iatrogenic injury. So this is one beautiful view endoscopically showing the V2, V3, VDN and ICA in a mucor patient that we have done during this epidemic. Post-operative care and follow-up is standard IV antibiotics with good CSF penetration, oral diuretics, stool softeners, then avoiding any strenuous activities, and lumbar drain, as I said, the use is still controversial and depends on the surgeon's preference mostly. So there have been studies, more than 150 vascularized flaps used for skull-base defect repairs, and again the evidence shows that high flow leaks, pedicled vascularized flaps have superior results compared to simple multilayer repair. Advantages of endoscopic approaches, as we can assume, are minimum disruption of growth centers, especially for children, no brain retraction and avoiding the morbidity associated with it, preservation of sinonasal physiology and function, good cosmesis and higher success rates. But as with any approach, the limitations here are accessibility, especially in relation to the frontal sinus, the posterior wall. So for any patient, the best thing is to identify the defect, identify the correct approach, take a proper consultation with your neurosurgical colleagues, the neuro-ophthalmologist, neuroradiologist, and the endocrinologist and physician whenever necessary, and then identify the correct approach for the patient for the best outcomes. Thank you.
Thank you, Dr. Bidu Sharma. Can I ask one question?
Yes, sir.
Say one patient with high pressure CSF leak, you repaired.
Yes, sir.
Patient comes with again recurrence of the CSF. What is your approach then?
So for high pressure leaks, first of all, we have to ensure that during the first surgery, whether we were able to identify the leak site or not, because most often the cause of failure is not being able to identify, and sometimes there can be multiple areas also. So if it is a BIH patient who is having a high flow leak, the cause could be raised ICP, and maybe he has more than one site of defect. So during surgery, firstly, if we have identified it, then at the time of closure, we have to be absolutely sure that there is no defect from any other site. So we can use intrathecal fluorescein has been used, but if that we don't want to do that, then even we ask the anesthetist to administer a Valsalva maneuver. So we wait for some time with positive pressure. Is there any leak further after we have done the repair? Then we can identify if there are multiple leaks. So that is the most common cause of failure. If the surgeon is sure that there was only one leak and that was completely sealed, sir, then we might have to go for re-exploration.
My point of asking is whether at the same time would you like to do any CSF diversion?
Yes, sir. If the patient is having symptoms of raised
high pressure
ICP,
leak patient can come back.
Yes, sir.
And then you go for the CSF diversion on the second stage.
Yes, sir. For that we always take a neurosurgical consultation for VP shunting if indicated. We do that accordingly.
Can I ask one question?
Yes.
Last.
In one of the slide you mentioned that if there is no active leak,
yes,
you
sir.
will do a free mucosal flap repair.
Yes, sir.
So then what is the indication of surgery if there is no active leak in your center?
Yes, so that was specifically for iatrogenic injury. Suppose we are doing a endoscopic sinus surgery and there's an iatrogenic injury. The skull base has been exposed. There's a defect in the dura, but there is no leak. For that, we have to repair it. We cannot leave it even if there is no leak. So that was particularly to the iatrogenic ones, sir.
And second thing is, in one of the your cases, you said that this pituitary macroadenoma was incidentally detected.
Yes, sir.
So you took out that adenoma also with the, or you
No,
just
sir.
repaired the site of leak?
We repaired the site of
That
leak,
was
sir.
a prolactinoma actually. So there is no need to remove that. It can be controlled with the drugs.
Cabergoline was
and
given
just
for
repair
that
the
patient,
CSF
sir.
leak. Thank you, Dr. Bidu Sharma. We go to the
Thank you,
next,
sir.
I think last talk by Dr. Suresh Sankla. A brief discussion on the complication avoidance in endoscopic skull base surgery.
Thank you, Rajneesh, for organizing this excellent workshop this morning, and I welcome all of you to this midterm skull base meeting. And and the endoscopic workshop. Okay, as we have seen, so many videos, and we all know that the endoscopic endonasal approach has been popularized in last 1 or 2 decades because of its own advantages, and we all know and are aware of these advantages why we choose the endoscopic approach. I will not go into the details of all these things. What I'm going to talk about is the complications. We also have several complications associated with the endoscopic endonasal approaches, and this is a paper published in 2015 which have really showed that about 25%, one-fourth of the patients suffer some or the other type of complication, to either intraoperatively or post-operatively. However, it was Amin Kasam who really classified these complications very systematically according to their locations and their types and nature, and and he suggested how we should really try and avoid these complications, and if there are complications taken place, then how to manage these complications. So he divided the complications according to their severity and into 5 classes. The level 1 or the first class was associated with the simple sinonasal invasion or surgery, and then the surgical invasion is increased progressively and graded wise until the highly complex endonasal approaches, which he categorized to grade 5, where the complication rate was the maximum in all areas. He also categorized the complications according to the pre-operative events and the intra-operative and post-operative complications. Practically, it is very easy and simple to look at these complications from the dissection area wise. So there is a sinonasal or nasal area, what are the complications, and then the complication taking place when we are doing this sinus dissection, and then the next is the cellar dissection, and finally it is the supracellar or paracellar dissection in the extended approaches. And these are the most common complications which we encounter. So I'll go over the rest of the presentation describing and discussing these complications which are more commonly taking place. So nasal complications are bleeding and crusting and nasal synecdoche and loss of olfaction and taste and disturbances, which we are all aware of, and I need not go into the detail. So what we normally do is we at the time of removal of the nasal packs, we put the endoscope in and just look at the condition of the graft and see if everything is all right. We also see the dissection area, whether there is any sign of infection or there is any sign of debris which really lead to the infection. This is after 3 or 4 weeks, we put the endoscopic again in only those cases where we suspect some kind of problem, and do a thorough wash all the time when we are examining the nasal cavity. And this way we can avoid many of the long-term complications arising in the nasal area. Then the sphenoid sinus. Sphenoid sinus is very complex and very variable structure. You may see the septi, intrasinus septi, which are so variably placed, and they can have a very serious implications if you don't look at them very, very carefully. So the anatomical disorientation is the one of the most important complications that we come across when we are within the cavity and we are totally lost, particularly when you are dealing with the cases where the bony landmarks are not seen very well in the sphenoid sinus roof. So you end up with injury to ICA or optic nerves or various or CSF leak. These are the most common complications. Besides that, you can end up with sinusitis, acute or chronic, and the mucocils. Like one of these patients, he developed mucocil because of the mucosal lining was not removed completely, and the sinus was packed incompletely. As far as our neurosurgeons are concerned, we have seen various types of CSF rhinorias, expected or unexpected. So this is one of the most common complications as far as neurosurgeons are concerned. The CSF rhinorrhea, which occurs from 0.8 to 16%, is the incidence. They are associated, or they may or may not associated with pneumocephalus and followed by meningitis. When all of these are present, the risk and the morbidity is very high, and some of these patients even really die because of all these infections and all these problems. These are various rates of CSF leaks which have been described in the literature by many skull-based surgeons, endoscopic skull-based surgeons, and this is one paper from Pittsburgh where the incidence rate, CSF leak rate, was as high as 43% in the major endonasal or complex endonasal procedure. Otherwise also, if you see the CSF rates have been very high in majority of these publications. When you talk about this pituitary adenoma where the exposure is minimal, you can come across the diaphragm here, the arachnoid can be breached here very easily, and that can lead to CSF rhinorrhea post-operatively with or without your knowledge. This is another patient who had the last bit of tumor removed, and then you can see you have injured some of the CSF, some of the arachnoid layer, and we have ended up with the CSF rhinorrhea. Luckily, it was observed during surgery, so we managed to pack it properly. As opposed to that, the intradural or extensive or complex endoscopic endonasal surgeries where you have to open the arachnoid and do a thorough arachnoid dissection in order to remove this tumor, like this in tuberculum meningioma, you are widely opening the CSF spaces, and you expect the CSF leak during and the post-operative period. So here you have to really do a thorough reconstruction of the skull base and complete dural closure in order to avoid these complications. So there have been, this problem has been studied very clearly and in very detailed manner, and there are left several publications, but thousands of publications, and based on the experience of previous speakers, they have really categorized the leak grades, CSF leaks. So grade 0 leak is the leak where there is no CSF is seen, even with the Valsalva maneuver. Why all these grading are important? Because then you can really design the closure and the reconstruction of the skull base depending on the severity. So grade 1 leak is a small weeping leak identified or not identified during the surgery. Then the grade 2 is the moderate leak, which is very clear during surgery, and grade 3 is the CSF leak, which is extensive and seen during the endonasal endoscope extended approaches, where you are opening the arachnoid and doing the arachnoid dissections. So all these grading really help us how to really go about packing the sinuses cavity, the operative area, and how to reconstruct the skull base. And these are very important. When you are following all these guidelines, your CSF leak has reduced to even less than 5%, and the reoperation risk, which used to be about 5%, has now reduced to 0.8% in the recent times. So this is a complete analysis of the grading and their severity, and here you can see that when the pre-protocol pre-cortical era, it was the CSF leak was about 1.9%, and the post-protocol, when the protocol is not followed, it is 2% in grade 1 leak. But as the grading and the severity increases, you can see very well that the pre-protocol leak has been much more than the post-protocol leak. So if you follow the protocol, you can definitely reduce these complications. So that gives us a lesson that you must really look at the CSF leak complication very systematically and proceed with the reconstructions according to the grade of the leak. This is the recent method of packing or reconstructing the opening, and this is basically with the help of the Haddad flap, which my previous speaker has really demonstrated so well. And this is the post-operative scan in one of our patients, showing nicely placed and completely reconstructing the skull base that we have opened. So nowadays, what is recommended is 3F formula, which is fat, flap, and fast mobilization. This is what we follow. This is one of our patient in whom we did the extended approach, and we really packed the cavity, dead space, with fat, and then put one small piece of fascia lata, which I don't know whether required or not, but basically it is the fat. And then if you have access to a piece of bone or cartilage, it is always advisable to put it there and fit it snugly, so that it can hold on with the fat and the fascia which you have put. And this has to be covered with the Haddad flap, or whatever the type of nasoseptal flap that you have raised and prepared properly. This is the glue which you use at the edges, so as to keep it in position for some time, and for few days. And then the sphenoid sinus cavity is packed in the usual manner, and so are the nasal packs kept for 3 to 4 days. But what is more important is the fast mobilization, and this has been seen that by mobilizing these patients fast, you can reduce, or you can restore the CSF circulation and the raised intracranial pressure situations very well, and that avoids CSF leak post-operatively. This is our one of our patient in which the Haddad flap and the reconstruction was properly done. And however, the avoidance is very important. We all know that the preoperative imaging should be really looked at and carefully assessed before surgery, and the dissection technique which has been described should be followed properly. And then the intraoperative identification of CSF leak is extremely important. Standard closure methods that we have discussed in the previous slides have to be followed in order to close the leak properly or avoid the leaks. And the prompt detection of postoperative CSF leak. Unless the postoperative CSF leaks are very minor, we really do not recommend to do the conservative treatment and straightway go for reopening and reconstructions. And the early and adequate repair, as I said, is very, very important in these patients. The second most common complication and serious complications is the carotid artery injury. The incidence is about 0.3 to 0.9% of the patient most of the time. It is the paraclival ICA which is very important, and for some reason it is the left ICA much more often injured than the right one. However, the higher risks of carotid injuries are associated with the history of prior surgery or prior radiation or tumor encasement by the tumor. So this is one of our patient, a 50-year-old male with growth hormone secreting macroadenoma, and these are the preoperative scan. And you see the right internal carotid artery's loop is too medial. It is very close to the midline. This we have realized of the preoperative scanning. However, we didn't realize that it is so close that we won't be able to open the dura completely. This is one of our very old patient done in the initial part of this study, and we used to use the knife to open the dura right up to the lateral angle, which we are not doing anymore. Here you have to use the Doppler in order to identify or localize the internal carotid artery, which we never did in the initial part. Now we follow this thing very, very carefully. Also the navigation, which help you localizing the carotid artery very, very clearly. And this is how.
Can we cut short because they are waiting just for demonstration downstairs?
All right, fine. So this was treated and managed post-operatively with the intervention techniques. This is another patient which was managed like this. So management is very, very clear. Identify the point of bleeding and immediately control it, and then the intervention, CT by angio, and then the endoscopic suit, and just manage it. Avoidance is very, very important. In that time of hypotension should be avoided. So bilateral carotid compression is not advisable, and minimal packing in order to just obliterate the bleeding site should be removed. tumor removal, further tumor removal should be completely avoided. So I just go fast over this thing. These are the avoidance point, careful assessment on the preoperative imaging, and rest of this all stuff which is well known to us should be followed very, very strictly in order to avoid the carotid artery injury. Incomplete tumor removal is another complications. There are several reasons of complete removal. One of the most important is the inadequate exposure, which should not be allowed. Poor tumor visualization, early descent of the diaphragm, adherence to infundibulum, extension into the cavernous sinus or in the supracellular intraventricular regions, giant or large or firm fibrotic tumors, and excessive bleeding. All these things are most importantly looked at and should be done carefully. So I will just quickly move out. Small artery injuries are another very important, and during your dissection you make sure that all these perforators should be preserved at any cost. Intracranial hemorrhage is another important, and one of the most important aspect of the complication is the endocrinological complications. The pituitary adrenal axis and should be maintained clearly. So you should preserve the pituitary gland at any cost. You should preserve the vascularity of the pituitary gland and infundibulum at any cost. The diaphragm which descends usually often hides the pituitary tumors, so you have to really handle it gently and keep it up in order to visualize all these things. So one of the most important point in avoiding complication is that you should follow the techniques which are standardized, and we use the binostril forehand techniques, and this is the operative arrangement. And it has got learning curve, so we have to use ourselves in various trainings and various cadaveric dissections programs very, very extensively before we really go to perform this surgery. This is the yearly endoscopic setup at in Italy, Naples, which is very, very important. These are few endoscopic hands-on cadaveric workshop organized by the Skull-Base Surgery Society of India, and we should attend all these things very seriously. Another important point is the teamwork. So I think I end my talk by concluding that all these points are very important, and one should really take them very, very seriously. Because of the lack of time, I am not really going into the detail, and I stop here. Thank you very much for your attention.
Thank you. Thank you, sir. Thank you very much. I think we straight go to the cadaver lab, where they are just waiting for the cadaver dissection to demonstrate. All of
For those who have registered observer, there is a sitting arrangement in the dissection room. They can attend there. The dissection proceedings will be relayed here also, so some can observe dissections from here also. Thank you.
So they are displaying here? आप यहाँ पे हो? अभी आता हूँ.
I'm good. Hi.
कैसे?
हाय, आई एम फाइन। कैसे हो?
बढ़िया सर।
चलो नीचे चलें?
हाँ हाँ सर, सर हम लोग ऐसे पीछे ऐसे
हाँ हाँ
कितने बार मिले?
to create a space here. Okay, I can, yeah. This is the flash. I can see the pattern here. You have to raise it further, then feel the this bony cartilaginous junction. There you have to do a bit little excision. Now this part is easy, but the difficult part is that we have to free it from above also, which probably I use the scissor for that, and below also. Okay, give me the scissor. Yeah. So I'm using the scissor first inferiorly to free it till posterior part. Then certainly this cadaver is not allowing space, so I will not be able to control it, but I'll try to be. You can see the flat is being cut. In most of the cases, if we use pottery, it is easily cut. Means already with the clear only we are able to separate it. Here I have to use this. Now we see we have this flat which I am pushing posteriorly. So the most important thing is we have to raise it far laterally. Otherwise, what will happen? We won't be able to part this slab and it could be damaged in the future dissection. This slab can cover up to 7 centimeters of surface defect. We should be able to pass it below. We can see the bone turning laterally. I think we are able to see this. So this entire slab along with the artery, till latermost part I have raised, and now I have parked it in the nasopharynx for future use. Now this entire bone is available for us for any maneuver. Without with the least possibility, we can cover it with some practice also, or maybe some piece of merosis, whatever we require. This is our sphenoid ostium. Now we can remove this bone safely to enter the sphenoid. So now to approach pituitary, there have been various approaches. The conventional initially microsurgical. I think many of the young neurosurgeons or ENT surgeons, they have not probably seen those things being used. There, we used to give a sublabial incision, raise the mucopericardial flap on both the sides, fracture the septum, the passage in the bony septum, and straightway we used to approach rostrum with a very narrow tunnel vision. With endoscope, there can be many ways can be done. There can be only single threaded two-hand approach, where in one hand I am holding this endoscope, with the other hand I am operating. For optic nerve decompression, I think that should suffice for this. Initially, surgeons they used to do like this only. They used to enter sphenoid and with one hand they used to do. Then binocular approach, where you open the sphenoid from both the sides and we remove just the minimal posterior part of the septum and directly inside the sphenoid sinus We used to, from one side endoscope, the other side instrumentation we used to do. Then there is for extended approaches, especially the posterior septum, where we remove the entire posterior bony septum. This bony septum, I will show how to remove. If we remove this bony septum, then the entire field is available for us to play. Now there is another concept, whether to remove turbinates or not. For pure pituitary midline simpler lesion, it might not be necessary. But sometimes for extended approaches, to remove one side of middle and inferior both turbinates, and you can get more space for instrumentation and all. So all these kinds of variations can be there depending on your need and how you are approaching. The key point is the way I consider as mining with sculpturing field. So you have to be delicate, despite being very, in bone removal, you have to be ruthless, but at the same time very delicate and meticulous. So on the other side, spinal dorsal, we are able to see this side also middle turbinate, superior turbinate, and this is spinal dorsal. I think it's very clearly seen. Again, there are divisions here and incisions here. So now what I will do, I will do posterior septum with me. Right. So this is the bone. We are able to see clearly from this side. I'll tell you one use of the flap also. So this hard also is coming view. Now the opposite side mucopericorneum flap. What to do with that? We have raised radar on one side. So what we can do, we can make incision on this flap here, mucosa posteriorly, inferiorly, and bring this mucosa forward and stitch it with this junction. So that this raw area is no more there, and it will heal in a very nice way. So we are directly seeing the rostrum. I think it's very clearly seen that. See, this mucosa which I have exposed on the other side, I have raised the flap. I can give one incision here, one incision posteriorly on this mucosa, incision inferiorly. Okay. This mucosa is clean off. Now what I will do, I will bring this mucosal flap forward. So you can stitch it here. Yes. And some people might ask that what happens to the needle functions and all. Posterior perforation is not that much symptomatic or troublesome. It's the anterior cartilaginous part perforation which is more troublesome and more symptomatic. So this posterior window, it heals nicely. approach is mainly for pituitary. But if you want to work laterally, then you might need to extend this entire window with removal of the terminates also.
Basically, at this stage, the neurosurgeon will join. Where the neurosurgeon stands and ENT surgeon stands is a matter of convenience. There are many ENT surgeons who like to stay here, and the neurosurgeon has to move to the opposite side and operate from there. But I am a very strongly right-handed surgeon and I prefer to stay here. So I just stand beside the ENT surgeon.
To remove the rostrum, there can be many ways. The fastest way is using a hammer.
I think this is one area which is still beautifully done by hammer. What they just if you use the drill, it is all flying in the air.
This lap is coming from the way, reverse lap is not here.
And that is another thing, the reverse flap, once he has reversed it, you have the normal before that, then you take the switch and make sure it doesn't come in your way of operation.
So, use a push hammer here in this gutter. Use a push hammer here in this gutter. You can see the bone is there. So then the rostrum in one chunk it will come out. We don't have push, I am using this drill. The reverse flap has to be same here. So if you put some ball or something, then it will be easy.
What we do is, this is always a problem. So best is get the flap down in the nasopharynx, put one mirror cell on top of it, and then start operating.
The same thing on the other side.
Mirror cell, as some of you have not seen, looks just like yellow, but it is a deeper and it doesn't get absorbed. And it swells up when you
See, it's dropping now. It was not dropping till now, but now it is dropping. These two cuts make it quite easily detachable, and maybe we can use some blunt out instrument to even faster. This rostrum has come out now. Now we will have a panoramic view of sphenoid. This reverse flap actually is coming in the way, maybe we need to remove it. What we are seeing here is this is the sphenoid cavity. Actually color. Actually color. Section दूसरा लगा Yes, so this is the inside of sphenoid. This is the sphenoid septum, the sphenoid septum. This is the other side of sphenoid. It is radiologically also smaller. And this is the this floor of platform. Dr. Devpujari will continue from there. Most important thing is to keep the view straight.